Hospital. My role in this is that much. I just help in facilitating, because Raghu takes care of all the neuromodulation and Vaishnavi, the pain part. Both of them work as a team to take care of the neuromodulation. And I just help them in facilitating wherever there are ifs and buts and these things. And with this, I will welcome two of our guests, Professor Sandeep and Dr. Sachin. And hope to be an interesting session, because neuromodulation for us, for a general person, it is restricted to DBS actually. That's all neuromodulation. But we all know that it's much more than that, and with Medtronic, the range of products they have for neuromodulation, I think we can achieve many more things. The main challenge with neuromodulation in India is two. One is awareness, second is cost. Awareness is poor and cost is high. That's the only thing. And just to make us aware of these things, this is a short session, 2.5 hour session, which Raghu has planned, and we'll see how it goes, and we'll hope to have a very good interactive session. I'll ask Vaishnavi to please introduce the speakers and set the meeting going. Vaishnavi is a senior consultant anesthesia and pain. She takes care of all the pain work.
Hello everybody. To all the doctors present here and all the doctors who have logged into our YouTube online, a warm welcome. Of course, it is a summer, so not a warm welcome. It's a welcome, just welcome. It is a new innovative session on neuromodulation. I hope all the people and the doctors present here find it interesting. So, two stars of this session are Dr. Sachin and Dr. Sandeep. It is a privilege to introduce Dr. Sachin Khandari, who is a medical director as well as a CEO of Institute of Brain and Spine Hospitals in Delhi. He is an academician. He is interested in spinal cord stimulation and dedication in neural modulation, as well as in spinal cord stimulation in paraplegics is outstanding. And he is a visiting consultant in multiple hospitals outside India, like in Uzbekistan and Bangkok and Tajikistan. He attained many awards, achieved many awards as Excellence in Sultanate of Oman in 2014 and recognition of exemplary work in Kingdom of Saudi Arabia. With this, I would like to invite Dr. Sachin Khandari to present his presentation here before us and share his innovative thoughts on spinal cord stimulation. Thank you, sir. They will be sharing the...
Okay. So I can control from here. Yeah, good afternoon everyone. I am Dr. Sachin Khandari. I am a neurosurgeon from New Delhi, and also I run a center for advanced recovery for paraplegics and other neurological condition patients in Hyderabad called Walk Again. That's a neuromodulation based rehab center. So we are here to discuss or broach upon the subject of neuromodulation. As per my end, we believe that electricity is a new medicine. We have had pharmacological interventions. We have done pharmacological neuromodulation by drugs, by intrathecal drug delivery. But as Sir correctly said, till now the general understanding for neuromodulation has been DBS only, or pain. But the scope has intensified and spread right from DBS for neuromodulation to DBS for psychiatric condition, down to high cervical stimulation for patients with persistent vegetative state or deep coma state, then for cervical injury, for upper limb movement and trunk control, then for respiratory paralysis following spinal cord injury, by cervical epidural stimulation or by thoracic epidural stimulation, then for brachial plexus injury by stimulation at plexus for complete or incomplete plexus injury, which doesn't have transaction, coming down to epidural stimulation for spinal cord injury that I am going to present upon, pain in failed back or other conditions, then sacral neuromodulation, like for that will be presented before you today, and peripheral nerve stimulation for sciatic nerve and other nerves in lower limb. So just briefly describing the SCI, as we all know, is kind of a dead end for doctors and patients both. Little hope to offer, quality of life suffers, precious human working hours and everything is lost. Our country has a very high load of the same leading because of we are a developing nation. The trauma and all are much more prevalent here than other countries. The safety guidelines are not followed too. So falls, accidents, violence, sports injuries, all this contributes to spinal cord injury. So today I'll be presenting mostly on starting with the dorsal epidural electric stimulation, something that we started 7 years back. As of now, we don't have any proven treatment modality to address the reorganization of neural circuits to improve the condition in complete paraplegics following dorsal spinal cord injury. So how does a completely paralyzed spinal cord work again? How is it possible for a dead neuron to work again? So this is what we do basically. It has been proven that when you apply a continuous low voltage current to the lumbar spinal segment, so it's possible to achieve voluntary leg movement. How that happens is that the spinal cord is not just a highway for transmission of signal from brain to the body. Spinal cord has subsectors located at different locations, which in turn supply the network they're intended for. Like we have something called, I'll go back to this again just to explain. This is at the heart of epidural stimulation, the central pattern generator located in the lower dorsal spine. For everyone who is walking, the locomotion signal goes from the brain to the CPG located at T12L1 in all individuals. And from there, the command is then carried on by the legs. So if there's an injury above the T12L1 level, and there's some anatomical connectivity remaining, not functional, still it is possible to induce this activity by epidural stimulation. The principles are three. Automaticity, that means this center, if you stimulate, by virtue of being the inherent virtue, it will produce cyclical motion of the legs, as in a gait cycle. Residual supraspinal connectivity, as I said, there has to be some anatomical continuity between the cord at that level and not a complete transaction. And training-induced plasticity. That means if you keep practicing that movement that you achieve by stimulation, you keep practicing, you make a new track, and that is the whole principle of neuromodulation. The system works as a prosthetic initially and as a treatment later on. Like when we implant a device, initially all the movement will be possible only when you're stimulating the spinal cord. That time the movement is occurring. But over the time, with training-induced plasticity, the system becomes so intelligent that you don't have to switch on the device. This usually occurs after 3 to 4 months, that you can switch off the device partially and still get all the movements possible. So as you see in short term, the circuit activation alone will produce the movement, and over the long term, the circuit remodeling occurs. So we have to treat spinal cord like a part of the brain which can be trained again. What to train is what we have to supply here. The device has been approved by FDA for pain since 1982, but the location and the parameters have been changed to suit the purpose of stimulating CPG. So this CPG, or the group of neurons, is like sinus area in the heart. It does not require a supraspinal structure to influence it. If it is influencing, well and good, the movement will be controlled. But inside per se, even if there's no cord above it, you stimulate this center, you will have a cyclical rhythmic pattern of the movement. Then once you stimulate and you get the walking pattern, you keep training on that to induce plasticity. So what does it achieve? Where does it lead us? So we can, with almost 90% accuracy, predict that the patient will be able to stand, take assisted step, or walk with the support of walker with voluntary limb movement. The sensory improvement is there, but not as much as the motor improvement, because the parameter for sensory improvement we yet not have deciphered. But for motor control, the current parameters we already have. We see sensory improvement across every patient but it is never 100% sensory improvement. Power you can achieve up to 90%, but the sensory maybe 50 or 60%. But still the patients can always feel the ground when they're stepping onto it and maintain their balance. Furthermore, it improves the bladder bowel control, autonomic functions, temperature regulation, and decrease of neuropathic pain and spasticity. So, what case to consider for epidural stimulation? What patient qualifies? Any patient who has anatomical continuity of spinal cord at the level, till the level of D12, is able to qualify for this treatment. The lower section T12L1, the distal 6 centimeter of the spinal cord at conus level, is the part that we need to stimulate. If this part is healthy, there's no cyst formation, no myelomalacia changes at this part, we can consider the patient to be a candidate for spinal cord stimulation. Intraoperatively, by intraoperative nerve monitoring, direct cord stimulation, and by radiology, we confirm the location. The lead that we use in this is 565, a paddle lead. This lead, by chance, the dimensions are matching the dimensions of the conus medullaris that we want to stimulate. Like our stimulation diameter is 6 centimeter, the lead length is 6.5 centimeter, and the width is 1.2 centimeter. So that just fits on the cord from end to end. And again, our purpose is not to stimulate the nerve roots here, but the spinal cord itself. So intraop, when we stimulate, we need to get all the movements on the table for hip, knee, and ankle on both sides by using a different combination of current, frequency, and pulse width. Once that is done, then the next critical step, where the main learning curve is coming, is the mapping process. Putting the lead has to be I think, the simplest process of the whole, part of the whole process. You identify the right case, check all the parameters. If the patient qualifies, you implant the lead, intraop, you confirm. But then the main challenge is how to convert that current and movement that you're getting on the table into a walking pattern. So we spend around 2 to 4 weeks for what is called as mapping process, taking 4 to 6 hours a day, where every muscle group, hip, knee, and ankle on both sides, is mapped for the current frequency that produces the desired motion. Then there comes a time when all the points can be combined together to get a gait pattern. Initially, the mapping is in a lying down position, then sitting, then on a harness. So by 3 weeks, we can get the patient to a point where on a walker, he can take a few steps. So I'm just sharing 3 cases, short videos. These were the difficult ones and the latest ones. So this is T7 complete, which we operated around 2 months back. So it was a stab injury at T7 and preoperative 0 power. Because it is T7, we also focus on the trunk control. This is after a month and a half. He's wearing these weight cuffs on the ankle for practice purpose. But for a paraplegic, 2 months after the treatment, this is, in my view, a pretty good recovery. And from here on, he's going to get better and better only, because only 2 months and this much recovery means the automaticity is still in play, the learning of the spinal cord is still in play, and 3 to 4 months, you should be able to walk even better. And coming to the next one. So this is a patient we operated around 5 years back, 2020, just before COVID. And This is day 1, where he's able to voluntarily do the hip flexion. This is after 2 months. So this was just at the time of COVID. So we identified few issues that was limiting us from calling it as the ultimate treatment or like significant victory over spinal cord injury. So I'll just come to those challenges, what challenges we faced. So one is the trunk control. So because the lead implantation is T12 L1 level, anything above that has to be, suppose somebody is a T2 or T3 injury, the segment between T2 and T11 is not supplied by any nerve. So how to get that trunk control? Then the proprioception. For walking, the sensation of balance and proprioception is more important than the power itself. So there's always going to depend on to hold on to something like a walker. Third, the challenge is knee lock, because knee lock is something which needs proprioception as well as the power. Your whole weight has to be on one leg while you're shifting the weight onto the other leg. And fourth was the moderate bladder bowel recovery. In fact, we published a study on 10 patients with sensory motor and autonomic recovery following complete paraplegia, epidural stimulation surgery. In that, we found out 60% people benefited in bladder bowel activity, but it's never enough to call them continent again. So in those cases, we supplemented with sacral nerve stimulation after epidural stimulation after a few months. So that's why we had to come into how to take this further, how to address the challenges that this stage has brought us to. Like they are able to walk but not good enough for community walking. So then we ventured into advanced neuro-robotic rehabilitation. And this is an area which is opening up. Till now, the physiotherapy or neuro-rehab has been considered a very passive part of the whole treatment. We are just like, it's referred to or condemned to kind of think, okay, you go there, keep doing. Neither we do expect anything, nor does the patient. Barring few surprise cases, you can never promise that the neuro-rehab is going to help you recover to a great extent. It has always remained a therapy and never a treatment. So our endeavor was to push the limits by neuromodulation to a level where we could promise somebody could be getting back to his normal life. So again, the principle used is by increasing neuroplasticity in neuromodulation. Whether you do it by invasive or non-invasive method is a choice that you have to make. Nowadays, if you have a patient of incomplete cord injury, we don't even recommend epidural stimulation or any other surgery. We directly suggest for advanced neuro rehab. So at the heart of this is something called, this is Cyberdyne. So can you mute it? So this is the world's only brain-controlled robotic or hybrid assistive limb. We've all heard a lot about exoskeletons, but exoskeletons are the only passive devices which walk and you feel like you're walking. They never help you recover walk. This is the one that works with your own brain's intent. That's why it helps you recover. It is used to learn to walk rather than a tool for walking. So what is different about Cyberdyne is that you wear some sensors on the legs and a robot. And it has been established that there's something called BES or bioelectrical signal. Even in a paralyzed limb, the brain's connection is always maintained. And when you think about a movement, your intent is carried to the skin surface, caught by the robot. Robot will make the movement that you intend to, and that movement is learned by the brain. So, and if you do a functional MRI after 3 months, you will see that the walking center is again responding in the brain. Patient shows recovery on a daily basis. So much so that is the only device in the world which is FDA approved for treatment of paraparesis in spinal cord injury and MS. So this is the mainstay of our walking treatment following spinal cord injury or paralysis. Again, the brain's intent is captured by EMG biofeedback based devices like Luna. Say somebody has a foot drop or weakness in one hip or leg or one shoulder. So this device can be used to address that. Like our cases where we had a problem with the knee joint proprioception and locking, this is what helped us achieve a better gait. The first video, the person is walking much better after 1 month as compared to second video which was done pre-COVID. Third, we were always looking for the ways to enhance the sensory recovery. So there's something called FPS, or functional proprioceptive stimulation. So this was developed by a French scientist who inserted a tungsten filament inside the nerve bundle and then muscle bundle and targeting the nerve to understand what frequency reaches the brain and what frequency does brain read as a movement pattern. So this helps us couple the sensory and motor improvement. So what I understand, the sensory and motor two pathways for recovery. Our recovery process, the focus mostly has been on the motor pathway. Proprioception also to some extent by exercise, but mainly motor pathway. But this is one device which can help us utilize the possibility of using sensory pathway as well. And this has helped us get very good results, especially in stroke and spinal cord injury, as far as the proprioception concerned. Then we recently started venturing into brain-computer interface, which has proven to be very, very effective in patients like this. So the principle is that if you perform a movement 6,000 times with the brain's intent captured via EEG and relate to a computer system and then to a rehab device, the brain tends to develop a new track for that movement in your brain. So repeated BCI control movement, the system is very simple. You wear, again this is FDA approved for stroke, you wear an EEG cap, connect to a computer that is then coupled to an FES device attached to one hand or one leg, which you tend to focus on. And the concentration level has to be above a certain percentage, which the computer calculates. The purity of intent, it calculates. You make a movement, and 6,000 such movement, you will have that moment permanently with you. So this is the new way of helping recovery of paralysis, the BCI. Then the last we come to is the interventional neuro rehab or connectomic guided TMS. So functional MRI we all have been using in different ways for surgery planning or other ways. But now one step beyond functional planning is something called Connectomics, where a personalized brain map is made and you get to have knowledge of your own networks like CE and DMR salience, how they're working, how they're aligned. And once you have that brain map, you can identify the circuit in the brain, say for Alzheimer, or for speech disorder or for paralysis. Identify a circuit which is not working properly. By a navigation device in OT, you can mark the spot on the skull surface. You know the voltage by which the circuit is lacking, and that can be then provided by the way of RTMS or by photobiomodulation. You can either decrease or increase the amplitude of the brain circuit as required. Photobiomodulation is by laser. You change the potential of the brain cells, and by RTMS, a proven method by magnetic stimulation. Then the last that we are just discussing as well is the non-invasive spinal cord stimulation. This device, as we speak, is already applied for FDA approval for bladder bubble recovery in spinal cord injury, cerebral palsy, and incomplete cord injury for walking. So this tends to deliver the same potential to the spinal cord, but by non-invasive method. So we train the patient with this device on stimulating the centers 1 or 2 hours a day. So it makes the method non-invasive, more useful for incomplete cord injury, and very cost effective. Now is just one short video to highlight how neuromodulation based rehab can be helpful to the patient. So this is post BG bleed. So 1 month after left BG bleed, 1.5 months. Especially the speech part, which we could help improve only by connectomic guided TMS of the brain. Yes, can we have this volume in this one?
और आप कहाँ से आए हैं?
मेरा नाम गौरव सिंघल है। ES सिसोदिया में रहता हूँ।
उम्र क्या है?
उम्र 41 है।
क्या करते हो?
Same questions and the quality of speech.
और आप कहाँ से आए हैं?
मेरा नाम गौरव सिंघल है। ES सिसोदिया में रहता हूँ।
उम्र क्या है?
उम्र 41 है।
क्या करते हो?
मैं LL
So this is same technology used for post-GB syndrome recovery. This is for NMO. But the idea is to harness the capability of the brain to relearn using technology and clinical skills so as to be able to promise recovery in every patient. This is case of incomplete cord injury managed only with neuro-robotics without any surgical intervention. This is incomplete cord injury with only grade 1 power in both hips for good 8 to 9 months after injury, and then treated by neuro rehab itself. This is for stroke. So that was all about what we intend to do in neuromodulation, and we want to spread the word so that the awareness first comes to the medical community and then to the community at large. But yes, it is not something which is now limited to DBS or pain alone. We can certainly explore other options. Thank you.
So it was wonderful lecture, sir. So we learned a lot. Most of the times when the patient comes with a stroke or something, we just tell them most of the times that he does need the physiotherapy, and whatever improves with the physiotherapy, that's it. We don't think beyond physiotherapy. This is eye-opening for us to further extend our care to the patient and where we can improve the lives of many people. So any queries?
Again, I told it's a question of awareness. When we talk of stroke, we talk only about acute care. How to do a clot retraction, and that's all. After that, it's leftover. So, a lot of scope of it. I don't know. Hope this awareness is more and more to do this. Thank you. Wonderful work.
Sir. Thank you.
Thank you, sir. It was very inspiring. hope we also expand our horizons on spinal cord stimulation. Now I would like to invite Professor Sandeep Prasann Vasavada, who is a great academician who has presented in various conferences and have publications more than 100 and citations more than 4,500. He is actually a professor and Department of Urology, Center of Female Pelvic Medicine and Reconstructive Surgery, Cleveland Clinic, USA. He is actually a editorial board member and reviewer for many national and international journals. Sir, it is really a privilege to have you here for the presentation. So please come on to the dais for your presentation.
Okay, thank you for the kind introduction, and thank you for allowing me to speak today. It's always wonderful to be back home. So this talk, it's difficult to follow a talk like I just heard. This is amazing stuff that's life-altering, and you saw videos that really show how it's changed people's lives. I think in a very similar vein, we can make different improvements with patients' quality of lives, and that's what I'm going to show you now, with how sacral neuromodulation can be used for bladder and bowel disorders. So many of you know, but what is sacral neuromodulation? In very simple terms, I tell the patient that we're going to place a small wire, we call it a lead, that will send small impulses and gentle impulses to the nerves that go to the bladder to then allow improvements with bladder control, urgency, frequency, emptying problems. It also works at the bowel level and the pelvic floor level to help emptying problems of the urination as well as fecal incontinence. So these are the main indications we typically talk about. Assuming it works, we go on to the implant phase. So in very simple terms, I try to at least tell the patients what that means. Relevant anatomy that many of us know, but the S3 nerve root is the one thought to subserve most of the bladder and bowel function. So that's the important nerve root that we try to aim for as we try to achieve our stimulation. This therapy is not brand new. This has been out for well over 25 years. And so this is something that I got trained in the early 2000s and have just sequentially each year from then on out done more and more cases. So you can see this timeline as it started in the 70s with research in California and then developed. We were one of the lead centers at Cleveland Clinic and then continued to develop. They got launched and approved in 1997, and after their approval, they've seen technology advancements that have allowed it to be a more office-based technology for initial trials, as well as the actual implant, which has been simplified as well, to now get to an MRI-compatible system. With also in the United States, we have a small non-rechargeable and a rechargeable system, both of which can be used for us clinically. So mechanism of action, again, I basically tell patients it stimulates the nerves that go to the bladder and pelvic floor and rectum to achieve its benefits, depending on, again, the main symptom they have: urgency, frequency, urge incontinence, emptying problems, or fecal incontinence. So some of the main indications, as I kind of mentioned, these are the ones we really talk about. So I think this is a patient group that I really try to make sure we're appropriately selecting patients. And we'll spend a fair amount of time on that because I think that's one of the mainstays. When I come to India and I'm speaking, especially on this subject, I like to make sure that people are understanding what the best patient population is to use that in. I don't want to take what we do in the States because some of it is insurance driven. Cost is a significant factor, and we know that. And so this is where I want to make sure, at least even if you're doing it in patients, so we're doing it in the patients who may serve best so you can get the best outcomes and get you the most interested as we go through the therapy. So these are the kind of listed therapies. And I put this note about who's perhaps not an ideal candidate. And so I know we have a multiple specialties here. So let's look at that. So interstitial cystitis is a painful bladder syndrome. So these are patients with significant bladder-related pelvic pain. I don't know if those are ideal patients. There have been research trials that have shown some patients improved, some didn't. So I don't think it's a strong enough role for those patients in pain and pelvic pain as well. Urinary retention that's obstructive. So this is a urologist patient who has a big prostate and they're obstructed and they have emptying problems. We don't want to do this therapy. They need to be unobstructed. They need to be anatomically corrected to allow them to void best. Neurogenic retention and neurogenic patients, I think I want to spend some time, and I'm sure we'll have some opportunity with the question and answer about who's an ideal neurogenic patient. Because in the States, we're not allowed to routinely do neurogenic patients in their basis. However, we know that patients have histories of spinal cord injury, but not permanent, not some of the stuff we saw earlier. So partial injury patients, we have MS patients who we still can do and do very well with it. Parkinson's patients, we have patients who have had other therapies that could have affected their nerves, including lumbar disc surgery. And if I look at a lot of my patients, many of them have some form of a little bit of a neurogenic background. So that's still a very significant portion of patients that we can do. But a significant spinal cord injury, so this is a complete injury or someone who can't walk, these patients, I don't know in the routine case is going to be an ideal state from which to do so. If they can't work the device or fail the trial stage of implantation, that's going to be a little bit of a problem too. Optimal patient selection, let's look at that. So this is the typical things that we would do for anyone, right? Medical history, excluding other factors, bladder diaries, urine testing as far as urinalysis goes, and then bladder testing, you don't need to do that, but I think can be helpful in some cases, as well as any form of upper tract imaging. Again, all of this is for urinary-based patient problems. So when we think about who is existing in your practice, there's a lot of these patients, and I speak to that from anyone here in the audience. If you're pain therapy, if you're colorectal surgery, GI, urology, obviously, neurology, neurosurgery, these patients exist in your practice. You're seeing them literally every single day. So I'm just asking you to kind of put your hat on and think about these patients and where they would lie. So in a urologist practice, they've had a BPH surgery, then they come back with refractory urgency symptoms, urgent continence. That's still a very viable patient population. I would say the same thing goes for urinary incontinence patients who've been managed with a sling and they still have urgent continence. That may be a patient who relies. Prolapse patients the same way. MS patients that many of us see in our practices, functional MS. So this is not the lady who's in a wheelchair or a stretcher, can't get up, can't walk, because even if this device helps, what is it really helping? If it gives her more time to get to the bathroom, if there's a functional issue and she can't physically get to the bathroom, it won't help. It's not going to make a difference if she leaks, right now here versus 20 steps over here. It's not going to make a difference, even if this therapy gives her a little bit more time to actually get to the bathroom. Refractory overactive bladder patients in the States, that's the majority of patients we do. And those who perhaps aren't really interested or suitable for onabotulinum toxin or Botox injections, because either you feel like they're not emptying their bladder, they have retention risks, or as I mentioned earlier, these patients with lumbar disc disease, because many of them have either before their surgery, meaning that's their problem, significant spinal stenosis, they have urgency, frequency, emptying problems, and or fecal incontinence, as well as patients after disc surgery, many of them have still continued problems with bladder or bowel control. This patient population can do extremely well with that. Contraindications, these are the ones we typically look at if they didn't respond to a trial, and we'll show you what the video looks like for the trial. And then some relative contraindications, as I mentioned down here. So how do I use patients with retention? Because this comes up a lot. Each time I've spoken here in India, I think there's a lot of patients who they believe are ideal candidates because they have urinary retention. We've seen them from the neurology services. We've seen them from, obviously, the urology services. So their bladder capacity shouldn't be too overstretched. So we usually say about 500 cc's or less overall capacity. They need to be able to do self-catheterizations to determine how well the therapy does work. Shared decision-making is going to go in place because these patients sometimes have improvements, but what level of improvement is important, right? If she catheterizes 4 times a day and now is down to 2 times a day, in the US we use a 50% threshold to allow implantation of the device. So we go on to the bladder implant. But if they don't, then we don't go on to that. Now, in someone who's voiding 0 cc's and all is catheterizing, and then now they're able to void 200 cc's and leave over 200 cc's, is that satisfactory? So again, this is the shared decision making that you need to put out to the patient. But these conversations need to occur. And so let's look at some of the basis for this. We have guidelines, our societies, both colorectal, so ASCARs, and then our AUA SUFU guidelines, which I was one of the leads for in the last several years. We've looked at this and felt that this has a strong role in the overall management of these patients. So this is the typical care pathway or discussion we would try. So we have a patient who comes in, they have an evaluation. If their main problem is urgency, frequency, or urge leakage, we'll mention that they should try some simple things: dietary management, physical therapy, biofeedback, medications, and if not, go on to one of the final 3 options, including Botox injections or neuromodulation. Similarly, for a patient with bowel issues, we're going to talk about the same basic things. Medications may not have as strong a role, but then we go on to the same discussions. Neuromodulation, I would say, is the simplest and easiest and perhaps most effective as opposed to anal sphincter repair. And certainly we're trying to avoid colostomies unless absolutely necessary, nothing else can be there. So again, screen patients in your practice. If they're satisfied with their outcomes, no need to discuss anything further. But if not, there's other patient options that we can do. This has been compared with Botox. As you know, in India, Botox is widely available, and a lot of patients with urgency, frequency, or urgent incontinence get Botox. I do a lot of Botox in my clinic. I do a lot. Now, every patient isn't a perfect option for Botox, but it's an option that we do tend to discuss. So when we compare the treatments, we have to be mindful that some of them may have the simple things that we talk about, but sometimes when you do the shared decision making, they may have a problem that they don't want to have the retention risks. They want to minimize UTIs because that's already their problem. And so when we go into that, we sometimes have to factor that into the next steps. Furthermore, when we've looked at Botox patients, we've seen a number of them tend to discontinue the therapy. Every week I do about 8 to 10 Botoxes. Do I see 8 to 10 a week? And if you do the math, because it lasts about 6 months that they're going to come back, just with Botox alone, my practice would be huge. And I don't know if it's because that number drops because they either get disinterested, they don't like the procedure, maybe they had emptying problems, maybe they had infections, or they didn't just like the procedure itself because it caused a little bit of pain. These are factors that we talk about. And so this has been looked at, and when you see as patients go beyond the first and second and third injections, it tends to drop off perhaps more and more. So let's look at neuromodulation and the 2-step procedure. So there's different ways that we can do it. As I like to tell the patients, it's the only procedure you can try before you buy. So you try it first. If it works for you and you like it, then you go on to the implant. If you don't get the improvement, we don't go on to the implant. Very simple. There's no other therapy that I really have that's an invasive therapy that lets you try it first. And this is what's neat about this therapy. So we're very recommending of this therapy to say, try it, see how much it helps. Worst comes to worst, it doesn't work. That's nothing really harmful is gone. The risks of the procedure and the evaluation phase are very, very, very low. So that's why I don't like to do that. So when we look at that, we try that therapy and we ask them, what are they trying to achieve? What kind of goals are you trying to achieve? Bladder control, emptying, is it bowel control? We typically look for at least a 50% improvement in symptoms. Is it emptying problems? Reduction in number of catheterizations, again, depends on their main problems. So evaluation options can be done one of 2 ways. We don't in India do the basic office evaluation, but it is available in the US and other parts of the world. So here it's actually the advanced evaluation, which is done typically in the operating room. This is a sedation-based case, so we usually don't do general anesthesia. If you do need to do general anesthesia, I would recommend a neuromuscular blockade that's very short-acting because we look for neuromuscular responses. So if your anesthesiologist says, I need to do this under general anesthesia, you can do it. just need to tell them they need to do a short-acting neuromuscular blockade. Otherwise, you'll never see the responses and you won't be able to tell if it's working. We can trial these leads then up to typically 2 weeks. I've gone beyond that, but typically it's 2 weeks. And we use fluoroscopy to place that. Assuming that works, we then go on to the implant 2 weeks or 3 weeks later. And that's the typical form. So as I mentioned, if they have an office-based evaluation, they go on to the implant. But if it didn't work or felt that it wasn't, then we do what we do here in India, which is the staged evaluation, which is placement of the lead. 2 weeks, if it works. 2 weeks later, then we place the generator, and that's pretty much it. In and out surgery, come and go the same day. As I mentioned, sedation anesthesia, so it works pretty well. I'm just going to show you this video because I think this highlights everything. This is one I did. I just shot it maybe a month ago. And so this is, I don't think there should be any audio on this. So this is just walking a patient through the options. We typically would have had a discussion in the preoperative area, certainly before that, even getting to surgery, discussing that. This was a 68-year-old lady with a few other issues. Main issues were urgency and urgent incontinence. We discussed various options. She had a voiding diary, which showed that things weren't very good. She actually tried a basic office evaluation and then went on now to the permanent implant. This is the simple setup. We don't really make it too fancy. We just use pillows. You can see where I want to make sure that I can get the C-arm underneath the table. So that's what I'm showing here. We just show the feet and ankles, and then a preparation. Our preparation is chlorhexidine-based and alcohol-based. I know in India they tend to like to use alcohol for this, and that's totally fine. I think that works very well. Make sure it's dried. Mark off the area that we're going to be operating in. Not only just to show that, but we want to show the anal sphincter. So we want to keep that area prepped. We're going to highlight or show the feet and ankles and toes because I'm going to place a grounding pad or electrode there. Now the representative is typically helping with that. We then take the grounding electrode and connect that to the testing electrode. And this is already here. And that's then getting connected right there. That connects to the external nerve stimulator, ENS. There's different ways you can do this. You can measure up from the sacrum, coccyx rather, typically 9 centimeters from the tip of the coccyx, measuring 2 centimeters over on each side, and then just above that another 2 centimeters to allow where the needle entry point is going to go. We take these 2 needles then, we can do a fluoroscopic way, which is what I tend to prefer. And so what you're going to see here is we try to find the medial part of the foramen to see exactly where to place this. So you can see the foramens are these little eyebrows that are right there that are really showing on each side. We want to be in the medial part of that. And so we want to be between that and the base of the sacroiliac joint. So that tells us roughly where S3 is. So I do this all within, this is probably 45 seconds to a minute. And then start to place the needles in, aiming for about a 60-degree angle. And we're trying to stay in a medial direction, kind of more up and down. So now you're going to see as I readjusted that, it's kind of more up and down and straight parallel. We want to be just at the level of the ischiopubic ramus. So I'm pulling those needles back. And right at the ventral surface is where we test. And so now I take the testing electrode. I'm going to look for what's called a bellows and then toe. So you can see the toe starting to move there. And then you can see at the bottom of the film here, the anal sphincter muscle pulling in. So this tells me we are in the right position. I look for the lowest opening threshold or lowest stimulation I can get, and then I place my dilators. So this is all, again, I've done these procedures in 20 minutes, 15 minutes, but usually it's about 25 to 30 minutes. We extend that incision site a little bit because we're going to do very a Seldinger technique-like to place this long, thin wire. We call it the directional guide. And we're going to see that go just a little bit past the needle, and then we're going to change that out. Now, I don't know if you noticed, but I already made a skin incision to give me a little bit of space because this dilator is going to go over that. I need it to be a little bit wider to puncture the skin. So now here the dilator's going in. We're going to push it in. It has what's called a radio-opaque marker. We want to make sure that marker doesn't go too far So you can see that just above the sacrum. Now it's going to push. We want it to be just a little bit above where that is. So about halfway through the sacrum is really where we want it, right about there. So that's the level where we're going to just use that dilator, 1/4 turn, and then I take my lead. The lead has 2 markers, which I want to be somewhere in between the 2 markers so I can allow the little barbs, we call them tines, to keep into proper position. We like to aim for a medial to lateral configuration because that's the direction of the sacral nerves. So we want to go medial to laterally. So if we're on the right side in this case, the patient's left side, we're going to go medial, lateral, outside to the left. We're going to go up to the 2nd mark and no farther beyond. That's actually a perfect lead position with a slight angulation downwards, 3 electrodes below, 1 electrode just above, and then we test. We test each one of those electrodes, and you can see at the bottom left, the toe flexing, and then the top one showed the anal sphincter muscle testing. After that, we just basically remove the dilator. We'll then deploy the lead, and that's the complete procedure. So once we've deployed the lead, that's it. We're done. We've tested intraoperatively. If I wanted to wake the patient up, I could do that. And so you can see X-ray then comes out. It's a medial to lateral configuration of the electrode. And then we make a small counter incision on the side from which we're going to basically tunnel the lead. That site is going to be the future site of the generator. So we're going to be right over on that side. Because she's awake or at least has sedation anesthesia, I put some lidocaine solution and then make an incision overlying that, and then we'll just kind of make and dissect that down. I'm going to show you really on the next video because this case we actually implanted her generator. On this one, I'm going to show you the actual just percutaneous wire. So when we're trialing it, we want to do this, so now we're showing tunneling the lead. So this is actually my fellow because no one else could film for me. I said, I'll film, my fellow will do the procedure. So the fellow is here. He's tunneling out to the incision we made on the side. This allows us to pass the lead over to the side incision. And that's then just unscrewed. And then we pass the lead over to the side incision. I'm just going to show you this last little step where we take that lead that's now tunneled over to the side and we're going to connect it to what's called a percutaneous extension wire. So this is the part that's actually going to go outside now. So I'm just going to show you this part here. So then we tunnel this to an exit incision just kind of near the midline that'll allow the connections between the external nerve stimulator and that lead. So we can place the battery as a temporary phase or trial phase. Again, we try to recapitulate the nerve itself. The nerve exits medially and then goes laterally. So we try to be really mimicking of that in its direction so we can allow the achievement of bladder and or bowel control. So when you look at some of the actual innovations that have occurred more recently, we have a MRI compatible lead. The InterStim X has a 10+ year battery life. So it's a pretty impressive therapy that is now completely available here in India. It has a smart programmer as well. So this can all be done remotely. The patients can then affect changes. There's different programs they can place. There's a button for what's called MRI mode. So if they'd like to have an MRI, they just hit the button, go in, have the MRI, hit the button again, and they can go back to full therapy. And as I said, this is a 10-year plus battery life, and it tends to work quite well. This is the same as the InterStim 2, which is a previous generation in terms of its size, but the insides actually are very different with updated battery chemistry, allowing it to last longer. So I'll just kind of get ready to conclude there. The INS pocket, which is the one incision on the side I made there, just understand there's a little subtlety to that. We want to be, below the sacrum, below the hip bone, not where they sit. So it's somewhere in between to make sure that that doesn't, cause pain or problems as they go on to things from there. And then, we can do some programming and things like that as we need to. So just hopefully you understand good indications, urgency, frequency, urgent continence. There's a wide variety of patients in all of your practices that are there, and I think you need to think about that. I'll tell you, in our practice, we've studied this pretty well. We've done well over 2,000 implants. 8 to 9 out of 10 of our patients go on to the implant. So they trial it. We're seeing about 80 to 90%. Now, this is at the Cleveland Clinic. We have a tertiary care, highly specialized referral patterns, but we do very well with the implants. To give you a frame of reference, I typically, every Friday when I'm not traveling, do these procedures. I'll do about 5 to 6 every Friday. So this is a pretty significant volume in terms of what we see and do. And it's all over. It's patients with urgency, frequency. Because I'm a urologist, I don't see as many fecal incontinence as our primary reasons, but I do a lot of dual incontinent patients because they have urinary and bladder and bowel problems, rather. So we do those patients as well. And then, as we touched on neurogenic patients, we definitely do some, but, the more milder neurogenics. MS patients, Parkinson's, maybe a history of lumbar disc disease, not as many true spinal cord injury patients, but we can talk about that. And then happy to answer any questions. And here's my contact information. Always happy, email, phone, whatever, just WhatsApp. Just text me, and I'm always happy to answer questions or thoughts. Thank you.
Thank you, sir. A small question to you.
Yeah.
So we have a subset of patients where there is prolapse, maybe uterine prolapse or wall prolapse, with continuous history of dysuria.
Okay.
They undergo many tests like urinary cultures and urodynamic studies. Everything will turn up to be normal, but still they have their dysuria. So what do you do for those kind of patients in your clinic?
So their prolapse has not been corrected surgically?
No. Not in every case, sir.
Yeah. So,
not in every case. The
Yeah.
prolapse was.
I don't think, because the prolapse, you have prolapse here, and dysuria can be due to many causes. There could be a bladder pain component here, and you are talking of sort of vaginitis. You know that there could be some sort of new. Maybe she's talking about the new onset urge which can come after correction of prolapse. Perhaps that could be thing, but I don't think dysuria itself. You're looking at some sort of pelvic floor because of the prolapse. I wouldn't touch that case personally.
Yeah, I agree with you. I'd be careful, but I think to your point, cystoscopy, evaluating for other causes, these therapies, really dysuria wouldn't be an option. But just in a patient like that, if I saw that patient, yeah, I'd make sure her vaginal estrogen status was good, because dysuria tends to respond extremely well to vaginal estrogens.
I've actually advised few patients about the vaginal Primavera cream, but still they have the complaint persisting. And the pelvic floor, almost all the patients, they are actually advised Kegel exercises. I don't know how much all the patients are actually having compliance on doing the Kegel exercises.
Okay.
Don't know how to help those subset of patients, because it is not one, it's like more than 5 to 6 patients coming with the same complaint.
Yeah, so Kegel exercises work, but as you mentioned, I think in a patient population where they're prolapsed, Kegling actually may make it worse. So we would teach them to relax their outlet. So this is working with our pelvic floor physical therapists to do pelvic floor relaxation to help them empty it better. Otherwise, dysuria patients will actually get worse with Kegels.
So that's something I feel that's a very important point, that pelvic relaxation. Even with a lot of male patients who have a sort of a dysfunctional floor, and they have fissure associated.
Yeah,
We're actually
absolutely.
planning to do a study on that. So these have to be taught to relax their pelvic floor. Maybe sort of reverse Valsalva blowout, and maybe if we can. Correct. How effective do you think your experience with biofeedback has been on these patients? On this, what you said, pelvic relaxation, it's very difficult to teach them. So do you typically give them biofeedback before you? Just digressing from this a little bit.
Yeah, no, absolutely. I do. I'm pretty aggressive with that. We send a lot of patients to pelvic floor physical therapy. When they follow up, if they still have problems, the one thing I just don't know in this scenario, is the prolapse and how much is that contributing to their problem. I don't want to sound that we're surgically aggressive because we're surgeons and we do these things, but in many of them, I'll think that is surgery something that can correct their problem. Again, you'll have a hard time getting me to say that surgery will correct dysuria. That's not what I'm trying to say, but I'm saying that it can help if nothing else is helping. I would say to trial before that, we would try a pessary, right, the ring or donut to try first, because if that helps and they said, oh my gosh, my symptoms are better, then okay, do you want to keep with your pessary or do you want to have surgery? Again, I see a lot of those types of patients in practice, so that's what we would think about. Yeah, does that answer your question? Hopefully, okay.
We have a whole subset of spinal dysraphisms.
Yeah.
So how much percentage of your cases will be these patients?
Yeah, very low. Why? It just depends what level of neurologic dysfunction they have based on what we think is causing their problems. Do they have an intact sacrum? Do they have neuromuscular responses there? I'm not saying I wouldn't try it, but I want to make sure that at least I can actually physically do it. There's probably been this many cases in my career that I have physically not been able to do it. And that's when patients, in the States we have a lot of big patients and there's other reasons, but in a normal situation with spinal disorder anatomically that I couldn't do it, very few. So I would say it's an option. And then seeing what their main problem is, leakage, urgency, frequency, or emptying problems to see if we can achieve benefit.
So I just wanted to ask you, one of the things that we see in spinal dysraphism is the distortion of the normal anatomical networks.
Exactly.
So so that's the thing that I'm still not sure. So for instance, we have got some patients who have traumatic spinal injury and they have very poorly compliant bladder. So how do you, and this is at a level that is higher, upper motor neuron.
Yes.
So in these subset of patients, have you tried, would it work? Because the compliance is so poor that 80 centimeters of filling, it goes up to more than 40. So we give them full anticholics, full mirabegron. We tell them about Botox. Most of our patients cannot afford Botox they currently. Maybe they would. Have you had an experience in these UMN patients where the lower tract would more or less be intact? I wouldn't say completely intact, but what has been experienced where compared to the elements, it probably won't be, anatomically it won't be intact.
Yeah, I think it's a smaller group, but if they have compliance changes, I worry that if I do this therapy and they said whatever their bladder or bowel symptoms both improve, I worry about urodynamically, how much am I improving? In other words, am I protecting their upper tracts? Because remember, in neurologic induced bladder problems, neurogenic bladder, one of the first tenets is protecting the upper tracts. Yes, we're talking about bladder and bladder control and incontinence and emptying. But if we lose sight of that because the patient says, oh, I had this neuromodulation device, my bladder is better, not perfect, but it's better. Is that, I don't think that's satisfactory for me because she may still have.
If that happens, we have to keep doing a UDS.
Correct.
So we had a small study with only 20 patients at the previous place I was, where there were patients who had tethered cord and they were corrected, and we did the UDS parameters. They actually improved. So maybe after neuromodulation, if there's on a trial basis, on a setting of a clinical trial, maybe if we do the neuromodulation and then follow up these patients, because there's nothing much we can offer them apart from Botox at this point. They can't do CIC because the capacity is just too small and they have upper tract changes with that.
Yeah.
So far the kidneys probably are okay, but we cannot predict how long they would still be okay.
Agreed.
So the question is, how do we improve the compliance short of doing augmentation for them?
Right,
and augmentation has its own issues with this subset of patients.
No question. Yeah, so in our practice we would probably do augmentation, Indiana pouch, Indiana augment, we call it, so catheterizable stoma, depending on age, or even a full diversion, ileal conduit. I fear that if we don't do that and they get, I even worry about Botox. So I won't have as many insurance issues as you may have here with Botox. I know I can Botox, I can improve their compliance almost every time. Is it good enough to see resolution of upper tract changes? Sometimes. If I do, I have to have a very compliant patient. I'm not talking bladder compliance. I'm talking compliant that they come back faithfully every several months for the repeats. And if they don't, if you're in India and they live in a small village and they come into a big city, this is a big problem because we know when Botox is working, their compliance is improved, pressures drop, kidneys are fine, you can follow them with an ultrasound. Then at maybe month 4, maybe month 5, compliance starts to worsen again, upper tracts change, and they, oh, okay, I'm starting to leak again, but I don't know what happens to those patients' kidneys with time, and I worry about that.
And I sort of totally agree with you because what happens is, I've seen spinal cord injury patients, what happens is to get to the hospital. This is a trauma that occurs typically in the low class, low middle class, because they're out working when this happens. 1, 2, to come to the hospital, they have to hire a taxi, they have to request their friends, their relatives. I have a lot of these patients on follow-up, and they come to me only when they have a problem. That's 2 years.
Right.
Years I tell them, this is what you have to do. I give them my number. Still, it's very difficult for them to get them each time.
Yes.
So they follow up once, maybe in 2 years. That's something. So
That's
do you really prefer to do in these patients an augmentation with the electrophysiology? I think that's also my first choice.
Yeah, I agree. No, totally. And again, they have to be reliable for that too, right? They have to be self-catheterizing. So you still need it. So if they're not reliable, I'll tell you what, in the States, we'll do an ileal conduit. We'll just do an ileal conduit, and that's it.
That's better than the kidneys fail.
Correct.
That's a
Right? Exactly. That's a disaster.
Sorry, some basic question. I've seen that they're putting the stimulator only on one side. Is that okay, or you put the stimulators on both the sides?
Yeah.
The S3 stimulation, that the electrode that you put in.
Yeah, it's a good question. So the default standard, our FDA approved, is 1 lead, 1 generator. I will digress and say it has been done, including by myself and others. There was some data that suggested 2 leads would achieve better, right? 1's good, 2 is better. We think that for a lot of things. However, as we looked at that, the level of improvement was very little. So to the point that it didn't make enough difference clinically to make it different financially. And then, so what we trialed is, 2-week trial. We would trial 1 lead, 5 days, another lead, 5 days, and then 2 leads, 4 days. So now we're at 14 days. And some patients felt like 2 leads worked better. Most patients, 1 lead or the other worked better, and then we just took that and then removed the other one. So it's a good question. I think just routinely, it's not approved in the US for that anyway. And then second of all, we've seen the benefits not really worth it.
The second question is actually, you've shown one of the slides saying post-operative prolapse, rectal prolapse. Now, suppose if it is helpful in patients where the anatomical neural plexus is disrupted surgically, or even patients who are undergoing neoadjuvant therapy followed by surgery for rectal cancer.
Yep.
We have a lot of these patients with LAR syndrome.
Absolutely.
Now, how does it benefit in these patients? Because
yeah, good question. And to your point, I think if the nerve plexus is disrupted, which it is, right, almost for sure, our success rates will be lower. But I have to ask, what other options do you have that are simple and easy? This one allows you to try it. So I would take a patient, so if you operated on them last week, they come back 1 month later, they have these problems. I might give them 6 months. You'll do some antidiarrheal medications, bulking, all these different things. And then if they still had problems, then I wouldn't hesitate to trial it. Yeah. But I would want to optimize my situation before I trial it.
but you have shown some benefit in patients with LAR syndrome.
Absolutely.
And also patients who have gone a pouch procedure, a J pouch for unulcerative colitis.
At Cleveland Clinic, we're one of the busiest centers in the world
I know
in
that.
those types of things. So absolutely, and I see those patients all the time. As a urologist, I see them because they've had a low anterior resection and now they have urinary retention or emptying problems, not uncommon. We've seen those patients improve as well. Same thing, it's like, what other option do I have? This patient has a major colorectal surgery, now she's catheterizing. No one talked to her about that, and now she's upset and they send it to the urologist. I'm the specialist. They send it to me, and I have to help her, mentally manage that, and then talk to her about something. We have to give them hope. This therapy is actually, this isn't false hope. It does work, and it works well. But I just say, I need to make sure your bladder volumes are lower. You're going to keep catheterizing more often. Here's what we're going to do. 4, 5, 6 months later, let's make sure that we optimize things so that we can get you the best outcome. And we've done fine with that. I won't say it's perfect. I will not say that. But I would say a majority of those patients, which is greater than 50%, do go on to implant.
Great work. Congratulations.
So I just want to just add to that. We see some patients I have put this patient on CIC, and they have come back 6 months later, and their cath volumes are for 50 ml. So I have been able to actually, with over 6 months to 8 months, many of these patients improve.
Correct.
So would you typically wait some time before you offer them an implant?
Yeah, absolutely. I think that's only good practice. 6 months, now remember, they're upset, right? They come to your office. How many times have they even been crying in my office because they didn't, they have an ileostomy, they didn't want that. They're having all these problems, temporary ileostomy, by the way. They're still having problems down below now. They're catheterizing. That's an upset patient, and she never knew, or he never knew about that problem. And so then, we kind of calm them down, talk about the catheterizations, frequency, and then what the goal is so that we can achieve this. I wish I had more options for, emptying problems, but this therapy is there. But those are, great examples of ones to at least give them some hope with. Very much so. Great questions.
Thank you, sir. Thank you for a
Thank
wonderful
you.
lecture.
Thank you very much.
Yeah. Now we'll break for the tea break. 10 minutes. Yes.
So something that has really taken away is those procedures which had no basis, like you had this juicer, wrapping and wrapping. Those things are out now because that's definitely it never worked, and there were small problems.
Yeah.
Short tea break of 10 minutes only in the faculty lounge. After that, we come back again for the rest of the presentation.
Variations
సో నెక్స్ట్ ఇది డైరెక్ట్ వచ్చేస్తుందా? ఇది ఎండ్ చేస్తాను నేను. ఇది ఒక ప్రజెంటేషన్. నెక్స్ట్ వైష్ణవ్ ఇది ఒకటి. ఓకే, ఈ రెండు ప్లే అవుతుంది కదా. ఓకే, ఇది డైరెక్ట్ ప్లే. నేను ఇక్కడ నుంచే కదా ప్రజెంట్ చేయాల్సింది, ఇక్కడ నుంచే ప్రజెంట్ చేయాలి. ఓకే, రైట్.
Neuromodulation series. Start just. Good evening. So I'm going to talk about neuromodulation in cardiovascular system, as it is an autonomous system, but still we have some scope in making some corrections of the autonomic nervous system here when it goes wrong. And I'm going to talk about this topic in these few slides: introduction, anatomy and physiology of the autonomic control of the cardiovascular system, neural circuits in cardiovascular regulation, neural modulation mechanisms, clinical applications, few case studies and conclusion. So the autonomic nervous system that regulates cardiovascular system is both sympathetic and parasympathetic system, and including blood pressure, it is both centrally regulated and as well as peripherally regulated. I know the diagram is little complex, but you don't have to worry about it. It is just simple as that. Like the main center is in the brainstem, that is the medulla oblongata. Even the telencephalon, there is a thalamic and hypothalamic connections are also there in the afferent systems. And the nodos is nothing but a ganglion which is present in the vagal nerve at the base of the skull, which enters into the jugular foramen. And these are the afferent group of the nerves which enters into the cardiac system, that is nothing but ICNS, intracardiac nervous system. Also it is called as a small brain of the heart. And in the efferent system, you can see many reflexes here: cardiocardiac, intrathoracic, spinal reflexes, and brainstem control. So, where all we can modulate the cardiovascular system to have a better regulation in the heart rhythm, in the blood pressure, and as well as symptoms of cardiac failure. So, as you can see in this, in multiple pathways, we can actually have the modulatory effect. That is tragus nerve stimulation, which is very simple and non-invasive stimulation that we can do. The other one is a carotid baroreceptor stimulation, which is called as baroreceptor activation therapy. The other one is a vagal nerve stimulation, which can be an invasive thing where it goes into the through IJV, we enter the right ventricle and we keep the electrode in the right ventricle and we pace the vagal nerve, and we place the stimulator just like a pacemaker. And there is a ligament of Marshall, which is between the atrial appendage as well as superior pulmonary vein in between, which can be ablated in the extracardiac approach or an intracardiac approach. And in the renal sympathetic denervation, this is done for patients with uncontrolled hypertension after polypharmacy has failed. And in the spinal cord, we can do spinal cord stimulation in the dorsal thoracic nerves to decrease the angina symptoms for the patients. And stellate ganglion, which we have a large number of case series we have, actually including the recent one, we have almost 54 patients for whom we have done stellate ganglion denervation, in majorly for the patients who are having a ventricular storm and having shocks in spite of having defibrillator in situ. They are having a good prognosis as of now. Optogenetics is using a particular light where we stimulate the stellate ganglion again. It also comes under the thoracic ganglion, and electromagnetic neuromodulation. So what is neuromodulation? As simple as that, it is like using electrical stimulus to stimulate the particular receptors. Here we concentrate on adrenergic, cholinergic and purinergic receptors to decrease or regulate the heart rate, vascular tone and blood pressure by using complex signaling pathways. So what are the techniques that can be used in cardiovascular neuromodulation? It is vagal nerve stimulation, which increases the parasympathetic activity. That means it lowers the heart rate mainly. Baroreceptor activation system, it again lowers the sympathetic tone. That is just nothing but carotid massage, how we do for a patient who was in PSVT. And spinal cord stimulation, which actually have effect only on symptom of angina, where all the medications and patient who's on nicorandil on multiple drugs to alleviate angina pectoris have been failed. And renal sympathetic denervation, which again decreases the sympathetic outflow, and it is for patients who are having uncontrolled hypertension, and kind of a TENS therapy for tragal nerve. So where all we can apply? For arrhythmias, for heart failure, and for uncontrolled hypertension. For arrhythmias, usually the thing that we can do is mostly stellate ganglion RF ablation when the patient is having ventricular tachycardias, even tragal nerve stimulation for atrial fibrillation. We have a follow-up of 5 patients who are on tragal nerve stimulation right now with the TENS machine, who are actually having a better results because they have shown decrease in the complaints of palpitations. The upcoming thing is the heart failure, where patients have decreased hospitalizations after doing the baroreceptor therapy, and the other one is the uncontrolled hypertension that we are already doing in the cath lab for renal artery denervation. And these are the few trials, like Innovate trial and Anthem heart failure trial have demonstrated that VNS for heart failure and atrial tachyarrhythmias, but unfortunately Innovate heart failure trial has been aborted in between because of increased number of deaths, but they couldn't actually detect what was the cause of death. And BEAT heart failure trial is for heart, as the name suggests, it is for heart failure. It is for the baroreceptor activation therapy, which they place the device at the junction of the baroreceptor and the atrium and the vessel, and they have activated it to decrease the symptoms of heart failure. Usually the patients have actually, the NIHA class of 3 has come to class 2 after this BAT therapy, and defeat heart failure and SES heart are for angina, and spiral trial for RAD. All have proved beneficial, except that SES for angina is a negative trial. So what are the challenges and limitations in doing this? The main thing is awareness and access for the new treatments for general public. Safety and efficacy have not been established yet because of the long term, because it's the recent trials, all the recent trials, we don't know the long term efficacy. As of now, FDA has approved only BAT as a therapy for heart failure, and patient selection is also important, and ethical considerations. So promoting awareness and encouraging future research and improving the patient care by optimizing individualized and patient-tailored treatment is very important. Thank you. I would like to call Dr. Raghu for gastro neuromodulation.
Daljit.
No, I think we are taking a baby steps in this. We are improving and we are sending more patients. The FDA approval is for VT storm sympathetic denervation. Mainly it is surgical, but nowadays we are taking help of our neuroanesthesia team where they are doing with the radiofrequency ablation. So second, RDN is also for hypertension, it is FDA approved, but RDN can be again used for VT storm, and there's some trial going on where you can do atrial fibrillation ablation along with the RDN. The outcomes are better if you do only atrial fibrillation ablation. Then only my question to you is, none of us know, like if you do radiofrequency ablation for VT storm, which we are already doing either left or bilateral, as compared to surgical, we are doing on both the sides and removing up to T2, sorry. So whether we don't have head-to-head comparison, whether we suspect that outcome should be far better when we do surgical and completely remove the ganglion, or when you're doing RF, because for my understanding, when we do RF in our heart, there is a cure, whatever one nerve we are doing. So we don't know the outcome after RF because this is less invasive. So if you are able to get a very good result at par with the surgical ablation, then this will be a very good therapy.
For that we need to have another cohort for surgical thing, and we need to do a RCT for that. That is one thing. And when you give the patient the option of surgical versus non-surgical and a non-invasive thing, maybe
Obviously,
patient,
they'll
obviously
choose
they
for
will opt for a
non-invasive.
non-invasive thing.
But surgical has a foot.
And to find out the ganglion exactly as how we
Correct.
do in the ultrasound may not be that easy for the head and neck surgeon to exactly spot the ganglion under the carotid at the level of C7. That is another challenging part.
Secondly, the one we are doing, I think Traeger's nerve stimulation, what we are doing, I think it has a very good antidepressant properties also. So few of our patients, even if AFib episodes are not coming down, they are feeling very good. So I don't know whether it's related to antidepressant properties than actually decreasing the arrhythmia episodes.
So whoever is depressed can do a tracheal nerve stimulation. Sachin wanted to say.
Same coming to the stellate ganglion. So how complete is the ablation? How to assess that? That's a question here. It's about in surgery it is 100% complete because it's seen and cut, and then that's what is the thing. And then what is the again when we ablate, the completeness is what we have a problem there.
Actually,
recurrence.
The Horner's is the sign of complete ablation of the sympathetic ganglion whenever we do it, but unfortunately, when we do RF ablation, we are not seeing for all patients, as we see when we give the volume of the drug.
No. What I'm talking is when do they surgical? It is stellate, half of the stellate, and then up to T3, T4, I think. So,
D2.
so they will all cut it off, and there is no
They
more.
just ablate the ganglion, sir. They will not go to the nerve roots.
No,
right?
there is no ablation. When they do the surgery, it is
yes.
whole thing surgical sympathectomy versus this one.
Yeah.
How we can compare both, because it's already taken out completely and then we have still a residue left. How much we have ablated?
So that is actually surgically they are doing actually neurotemesis. But what we do by RF ablation is maximum we can achieve is axonotemesis or neuropraxia.
Yeah.
So there is always chance of
Yes.
regeneration. So over a period of time, definitely there will be a regeneration.
Yes.
And when that happens, we need to redo the RF again. And by repetitive RFs, the duration of the RF will actually increase.
Okay.
I mean, like the frequency will come down. The patient requires less RF ablations when compared to the first one.
Sure. Thank you.
Actually speaking, there is no problem because it's a very minimally invasive needle. There is no problem in repeating. The patient will also not mind unless, because surgery-wise, again, it's a challenge sometimes. Completeness, as you told, but it becomes a maximally invasive thing.
What is the youngest age you are comfortable to do this? Newborn, you are comfortable to do this?
So most probably no, ma'am, because we don't have any studies and we don't know the parameters at which, because they are all unmyelinated neurons.
Because surgical sympathetic denervation is done in newborns also. Okay. If there are BD bronchiopathy syndrome and all. So what is the youngest age we can refer the patient for?
But the youngest that we have sent to is 10 years.
That, okay. But that child did really well. He's a long QT syndrome with the PVC burden. He had symptoms PVC burden of 32 to 40%, which dropped down to 1%. So he did very well. We did only left sympathetic denervation for him.
Thank you.
Just
Next.
to add, last time we were discussing with Narasimhan sir, Vaishnav and me, sir was saying the sympathetic ganglion, what we are doing RF is like based on a Shashan tubercle, one single anatomical landmark. So if we could establish the exact location in every patient by MRI and ablating that and establishing the completeness of the ablation, probably we might get better results. So probably we are working on the thing with the neuroradiology to identify the things probably that we'll do with the time.
Active wise.
So good evening everyone. So I am presenting neuromodulation in GI disorders, which is in fact vagal nerve stimulation. So vagal nerve stimulation is very well established and FDA approved for the epilepsy and major depressive disorder. And emerging indications nowadays started using in inflammatory bowel disease and irritable bowel syndrome and functional GI disorders. So there are various mechanisms which are the IBS or IBD are resulting from is because of the symbiosis of the bacterial the bacterial colonization then the barrier breakage, and the abnormal inflammatory response. So which indirectly destroys the ENS, this enteric nervous system, which is independent of the brain. So sometimes we call the brain nervous system is another brain, so which has a control over the brain because of the neuromodulators which it releases, like serotonin kind of things. So the VNS acts in three different mechanisms, to predominantly the anti-inflammatory pathway, in which the connections, when we stimulate vagus nerve, they stimulate the hypothalamus, then the pituitary, then the adrenal cortex is stimulated, and where the cortisol is released, and which results in a immunomodulation. The second thing, by the connections, improving the connections with the insula and other areas of the brain, it also helps in the decreased perception of the pain. And the third is the ENS modulation, this enteric nervous system modulation with the secretory activity as well as the movements. So by using the same principles, there is various clinical trials which they try to manipulate the vagal tone in a different ways. So transdermal nicotine patches or nicotine enemas and everything. But they showed the significant improvement, but there was a side effects of the nicotine itself, and the drug delivery was a problem. So there was inconsistent delivery with the drug as well. So then came with the vagal nerve stimulation. The earlier studies implanted cervical vagal nerve stimulator and did the studies, and which showed significantly good results. So these are the various modalities of vagal nerve stimulation. Invasive, which usually do for the long-term patients like drug refractory epilepsy and major depressive disorders, and other cutaneous devices where we can stimulate the vagus nerve in the cervical region or the auricular branch of the vagus. So these two are very easy to use. Once we educate the patient, they can do at home also. So the evidence with the IBD, this is the first pilot study, which 7 patients, out of them they used this implanted cervical device, 1 hour stimulation a day, and they found the significant improvement in the inflammatory markers, and the disease remission was seen in 5 patients at 6 months without any major adverse effects. So they also measured this inflammatory markers like IL-6 and TNF alpha, so which correlated negatively with increased tone of vagus nerve. So if the vagal nerve is more working and the cytokine modulation was there, and inflammatory markers were decreased. So this is another thing, is irritable bowel syndrome, where they did 42 patients, 4 weeks stimulation, which was a transcutaneous auricular nerve stimulation, which showed that complete bowel evacuation and the number of episodes better, and the pain scores were improved. So there are the very less number of studies at present. There are 7 RCTs which were used for the different indications like abdominal dyspepsia, irritable bowel syndrome, or the Crohn's disease and ulcerative colitis, or the functional dyspepsia. All of them showed a significant result in terms of the pain scores, the bowel habits, even they have the cognitive improvement, like ma'am said. Now the mood elevating property of the vagal nerve, they also help them. So there's another pilot study for 12-month pilot study which showed the significant reduction in the gut TNF alpha, CRP, calprotectin, and the safety and tolerable wise, when invasive, we have the surgical risk, though we can do it, but it is associated with some surgical risk, and it is costly also. But it's a transcutaneous VNS. It's very affordable and safe, and patient can do at home very easily. So the adverse event with the transcutaneous VNS are very minimal, with the skin irritation and transient discomfort till the patient adapts to the stimulation. So comparison with the other biological therapies, they have the high cost and the immunogenicity, and the compliance is very poor because of the side effects, whereas the VNS is very cost effective and patient friendly delivery. And we would like to, as our center is one of the good center for gastro patients, so we will be probably will be looking forward for larger RCTs in IBD and IBS, and we might optimize the stimulation parameters for various patients depending on their immunological markers or something. And we can do personalized modulation if we could establish some markers and setting parameters. So this can be used as an independent or adjunct to the pharmacological therapy. So to conclude, the VNS represents a promising adjunct in GI disease management, and it has dual anti-inflammatory. At the same time, it has anti-nociceptive and antidepressive properties. This is strong biological plausibility, and early clinical support is there, and we can call for further validation and standardization. Thank you. Anything? No gastro, no. Yes, probably so. So now I invite Vamshi for neuromodulation in the headache.
For headache. So though it is a broad topic for headache, I'll be dealing mainly with migraine because it is a poster boy for chronic headache in adults. So first of all, is neuromodulation really required in headache or in migraine treatment? Yes, because we clearly have a subset of patients with migraine or chronic headaches who do not tend to receive any benefit with the conventional treatment in the form of amitriptyline or topiramate or sodium valproate or beta blockers. And those are clearly refractory to the normal abortive medications such as NSAIDs or triptans or dietins. So that subset of patients will clearly require certain amount of extra help in the form of neuromodulation. And in those patients in whom conventional pharmacotherapy is contraindicated, like in patients with multiple comorbidities or maybe in patients with pregnancy, or simply when some patients want to try a non-pharmacological method rather than going for the conventional treatment. So it is a very well established system, that is a trigeminal vascular system, which is known to propagate migraine. This picture I have deliberately put because it will show us various regions in which we can actually do this neuromodulation, whether it is in terms of the spinal segment of the trigeminal nucleus, or it is in the form of thalamus, or whether directly into the cortex. We know that it is all highly interconnected, and that cortical spreading depression will travel through all these pathways, resulting in migraine propagation. So based on that picture, we can either directly stimulate the scalp through transcranial magnetic stimulation, or direct current stimulation of the scalp, TCDS, or supraorbital branch of trigeminal nerve stimulation, which is directly by stimulating the trigeminal nerve itself, or vagal nerve stimulation, because we know that within the cranium there is an extensive connection between trigeminal nerve and the vagus nerve, especially because of their overlappings at the region of periaqueductal gray matter and also in the thalamus. And greater occipital nerve stimulation. This greater occipital nerve is a branch of second cervical nerve, which we know goes on to innervate the spinal segment of the trigeminal nerve. So thereby stimulating this greater occipital nerve will also result in migraine, will result in improved management of migraine. And finally, the invasive method, that is the deep brain stimulation of the hypothalamus or the ventral tegmentum. So the first study and the most quoted study is the single pulse transcranial magnetic stimulation for acute treatment of migraine with aura. So this is a very well done study which was published in Lancet in the early 2000s. It is a RCT, double-blinded parallel group study and sham control trial. So it's a very high quality evidence, and this clearly showed that the response rate at the end of 2 hours and at the end of 1 day and at the end of 2 days with transcranial magnetic stimulation is statistically significant when compared to sham stimulation. And this device has been approved by the FDA also. And we don't have any high quality evidence for transcranial magnetic stimulation for chronic prophylaxis for migraine. The one big study which was done is ESPOUSE study, but unfortunately it's a prospective single arm open label observational study. So we know that it is not a very high quality study, but definitely it showed that there is a significant improvement in the 50% responder rate in patients who received transcranial magnetic stimulation compared to those who received sham stimulation. But all things said and done, it is not an RCT. Then coming to the second modality, which is the stimulation of the trigeminal nerve. So basically, they will be stimulating the supraorbital nerve, which is the first branch of the trigeminal nerve. And then this particular study which was done, it is for the acute management of migraine, again not for the chronic prophylaxis. And in this study, they showed that there is a significant improvement in the pain at the end of 1 hour, 2 hours, and also at the end of 24 hours. And hence, even this device, which is called a Cephali device, has been approved by FDA for acute treatment of migraine. Unfortunately, there are not many studies which are available for understanding the efficacy of stimulating this trigeminal nerve for chronic prophylaxis of migraine. And then the third modality is stimulation of the occipital nerve, greater occipital nerve. This is the first study which was published is again in the early 2000s, but it failed to meet its primary endpoint. That is, at the end of the study, they found that it's actually a well-done study. It's a multi-center, double-blinded controlled study. But they found that there is no significant difference between the greater occipital nerve stimulation and versus sham stimulation. Some of those authors again did one more study about, I think, 4 or 5 years later. In this, actually, they found that, yes, there is some amount of improvement for migraine prophylaxis with the usage of greater occipital nerve stimulation. But the number of side effects which those patients had in whom the greater occipital nerve stimulation has been done is very, very high. And therefore, subsequently, this stimulation of greater occipital nerve, especially through invasive monitoring, has been abandoned. And the fourth modality is a combination one. That is, they have stimulated both anteriorly the trigeminal nerve and posteriorly the greater occipital nerve in a non-invasive manner. And this study showed that this device is particularly effective in controlling the acute management of migraine at the end of 1 hour, 2 hours, and 24 hours. And this device is also FDA approved. Coming to the fourth modality, that is the vagal nerve stimulation. Again, this is the PRESTO study, which was published in Cephalalgia, and they found that for acute management of migraine, vagal nerve stimulation externally resulted in better control of headache at the end of 1 hour and also at the end of 2 hours. And the same vagal nerve stimulation has been studied for prophylaxis of migraine, for chronic prophylaxis. That is a premium trial, again published in Cephalalgia. But here they didn't find any meaningful improvement between two groups with respect to the 50% responder rate. But the explanation which they gave here, we can see that the sham device inadvertently also had vagal nerve stimulation, and probably that's the reason why they couldn't find any statistically significant difference. But everything said and done, it showed that it is not highly useful for prophylaxis. So at the end of all these major studies, if we look into the meta-analysis, they concluded that there are different modalities in which we can try neuromodulation for headache, both for acute management as well as for chronic prophylaxis, whether it is in terms of transcranial direct current stimulation or transcranial magnetic stimulation, or any of the other methods which I have shown you previously. And finally, they concluded that the quality of evidence is very poor and there is a need for large, well-conducted studies in future. And the same thing has been again reiterated in the systematic review of clinical trials published 4 or 5 years before. And here we can see that most of the studies are either not blinded or they don't have any sham control. So ultimately, they also said that the quality of evidence which is there right now is not of great quality, and there is a urgent need to do furthermore better RCTs before we can conclusively say that these kind of non-invasive methods or for neuromodulation or invasive methods for neuromodulation are useful either in acute management or chronic prophylaxis. But within the data which has got accumulated so far, we can at least say that for acute management of migraine, yes, there is some role, some good quality studies which are there, which are available. But for chronic migraine prophylaxis, we still need better studies. So finally, based on all this meta-analysis and also based on the systematic review, the European Headache Federation had given a position statement in which they reiterated the same thing again, saying that as of now we don't have any good quality evidence, but yes, there is some role for non-invasive methods to try before going for any other invasive modalities in patients who do not conventionally respond to the pharmacotherapy for migraine. That is especially true for acute management of migraine rather than for chronic prophylaxis. So in conclusion, there are different modalities either in terms of trigeminal nerve stimulation or greater occipital nerve stimulation or vagal nerve stimulation or a combination of those nerve stimulations, or even transcranial magnetic stimulation or transcranial direct current stimulation. Several studies are there. Most of them which have good quality evidence showed good amount of improvement, statistically significant improvement in the management of acute phase of migraine. But when it comes to chronic prophylaxis, we don't have so much of good quality of an evidence. So probably there is a dire need for that. This device, I just put it here because it's a Nerivio device, which most of us might be seeing. These representatives from Dr. Reddy's might be visiting us every Saturday. So this device is also FDA approved, but unfortunately I couldn't find the exact data from which they got that FDA approval. But they claim that there is this particular device, which costs about 16,000, gives good amount of relief for acute management as well as for chronic prophylaxis. But like I said, I didn't really find the data as such, but this has been FDA approved. This device is currently available in India with Dr. Reddy's. Okay, fine, thank you.
Yeah, so all the neuromodulation we can use for acute thing, not for a preventive strategy.
Yes, they claim it for both acute migraine and for chronic, both. They are saying that 50% reduction is there even for prophylaxis also. Prophylaxis means you have to wait 24 hours. Daily for some time. Every day, yes.
All the devices are like that.
There are so many facts that there are some 40 hertz stimulation, both in terms of either tactile or visual or sound. If we search Google, there'll be multiple things. They say that they'll be reducing not just migraine, in fact even epilepsy also. That 40 hertz stimulation, all these things. But the quality of evidence is not very high. But nevertheless, it is
we have, madam. We are using TENS for that. We are using TENS mission for that. We can try. That patient has to buy. 5,000, 2,000.
1,500 Australian dollars.
No, 150. No. It's around 3,000 for this thing and 6,000. No, 6,000 for the device, around 6,000 for the electrodes. Or we can use our the TENS electrodes also. We can modify and use for some time. Yes, it's affordable, madam. It's very much affordable. 10,000. City also.
Actually, none of these studies included pregnant females, ma'am. We don't have, in pregnancy, none of the studies they have included pregnant females or children or epileptic patients. But if we look into the mechanism of action, probably it should not cause any teratogenic effect. They didn't recruit, but most likely it might not exert any teratogenic effect.
No, I think it is not teratogenic. The electrical stimulation increased the activity of the uterus. That's the thing, probably. Not the teratogenicity.
I mean, vagus nerve, ultimately...
stimulation.
We
can. Anyway. Thank you.
Sir, So the gist of today's neuromodulation thing is don't go behind the adrenaline rush and increase your sympathetic activity. Try to meditate and increase your vagal tone. Thank you for attending the session.